Hey guys, what's up? It's Stephanie. Welcome back to my channel. So in the video today, I'm going to be discussing how my 5th month in a physician assistant residency slash fellowship is. Hopefully this video is helpful for you, for those of you who are wanting to do a residency and or fellowship. The name is interchangeable depending on where you apply to. Some programs call them residencies, some of them call them fellowships, etc. So regardless, it's the same thing. So hopefully this video is helpful for you. For those of you who are currently in PA school and are thinking about applying to one, whether it's in emergency medicine, whether it's in surgery, I've seen some in even family medicine, I've seen some in internal or hospital medicine, and the current one I'm doing currently is in critical care medicine. So hopefully if I speak about my experience, it'll be able to persuade you on whether going to one or not. I have to be biased. I highly recommend one because I felt like I've learned so much through this residency and or fellowship since I graduated from PA school. Definitely, the knowledge that I have now would have taken a longer time for me to get if I had not done a residency. Plus, critical care medicine has a huge learning curve, and as a new grad, having a residency and or fellowship is going to help you go wherever you want, and that's really also one of the main reasons why I decided to do it, because I want to be well-rounded. So let's get into it. So I'm currently a critical care medicine physician assistant. Like I said, I'm completing a critical care medicine residency, and this is going to be my 5th month. The rotations I've done so far, my 1st month was surgical trauma, my 2nd month was neurotrauma, my 3rd month was neurovascular ICU, my 4th month was surgical ICU, and my 5th month, which I'm doing right now, is cardiothoracic ICU. Definitely by far, I have to say this is one of my favorite rotations thus far because, and I'll be honest with you, during PA school, definitely anything cardiac-wise didn't interest me much. I found it was all right, but I didn't find it very interesting. I found more the GI and the ID portions, infectious diseases, of PA school to be a lot more interesting. But I do have to say that just being in the cardiothoracic ICU is just in a different world. And I really liked this rotation so much because it's all about hemodynamics, and you get to learn the physiology of how the heart works in depth. And that's what I really like about this rotation. In PA school, of course, they teach you, but I would say kind of not as in depth as the residency that I'm doing right now is. So I got to really learn in depth of how the heart works, what is, of course, the preload, what is the equations behind the cardiac output, which we already learned about in PA school, but what really is cardiac output? What defines cardiac output? The hemodynamics, like I discussed. I learned about LVADs, so the left ventricular assist devices. What are they? For example, ECMO. What does ECMO do? What is the hemodynamics behind ECMO, right? And the different types of ECMO that we have, and why is one patient going to get this type of ECMO versus this type of ECMO, and just what to look out for when an ECMO machine is not working or the patient is kind of fighting the ECMO machine. And so I really like this rotation for those reasons. I got to see a lot of patients that were having transplants of their heart, lung transplants, how to care for these patients that have these lung transplants. That's something that they don't teach you in PA school. It's different, especially your lung transplant patients. It's a different physiology or pathophysiology once these patients get these lungs. So I really like this rotation for those reasons. So how were my days? So my days were pretty long. I would work 6 days a week with 1 day off. Monday through Friday, we would do usually about 6 a.m. till 6 p.m. Sometimes we would get off at 6:30, 7, depending on how busy, of course, the cardiothoracic ICU was. I did this rotation in the month of November, and so during that time, we had a lot of patients that had COVID-19, and you would see a lot of your severe ARDS. So we had some patients on ECMO. And so especially if you have a patient that's being transferred to you and they're crashing, I always like to stay for those cases because you get to see actually the physicians place the ECMO in the patients. And I think that's very just interesting. So I really like this about that rotation. So we would go Monday through Friday, 6 a.m. till 6. And then on weekends, we got off early around 1. So usually at 1, either a thoracic fellow resident would come and relieve us, or a cardiothoracic resident would come and relieve us. And so I got to work alongside during the week. We would round with my attendings, and most of them are intensivists. There are critical care medicine doctors. And then some of the residents that I was with, that we rotated with, was a lot of them were surgery residents, especially your interns and or anesthesiology residents, and then also your cardiothoracic residents were some of the ones that I rotated with. And I really like rotating with them because you learn a lot of things from them, and we're all the same. We all don't know how to care for these patients because it's a very particular, specific group of patients that you have to make sure that you treat them appropriately. So I really like that about this rotation, is that we learn so much together. And from anesthesiology, they definitely provided me with a lot of recommendations on how to intubate patients and how to ensure that you're getting everything proper before you intubate a patient so that nothing goes awry or nothing happens. And so I really like that about, for example, working with your anesthesiology residents. So yeah, so let's get a little bit more into it. So a lot of the patients, like I said, were post-CABG, so post coronary artery bypass grafts. I really like that about this rotation, is that you got to learn how to treat for these patients, how to treat them, how to care for them. What are the signs to look for? Like when you know where a patient is going to maybe cardiac tamponade, which is one of the huge red signs or postoperative complications for these patients if they start getting hypotensive. That's definitely one of the things you have to have on your differential diagnosis. Of course, there's a lot more things you want to have in your differential diagnosis, but that's definitely one of them. Valvular ruptures, right? We think about these patients that are post-CABG. And these are one of the things that you want to have on your differential diagnosis. I got to learn a lot about your vasopressors and why certain vasopressors are used in the CT ICU. For example, all the other ICUs, usually the first vasopressor that we go for is norepinephrine, right? And of course, there's a lot of studies. I'll probably go into it in the next video, just in regards to why norepinephrine is a lot more superior than, for example, dopamine. Dopamine is one that we definitely don't use anymore. And then you have epinephrine, you have phenylephrine, etc. You have different types of vasopressors. But I really got to learn why we use norepinephrine, and then why in these patients that are post-cardiac, anything cardiac related, we use epinephrine also, right? And so I also got to learn cardiogenic shock. And it's one of the things that they told us the first day that we rotated there. If you don't learn anything during this rotation, learn how to recognize cardiogenic shock. And I really like that about this rotation. I got really familiar with recognizing cardiogenic shock and just how do you treat cardiogenic shock. And how my morning started was I would get there at 6 a.m. I would pre-round on my patients by 7:30 a.m. and then at 7:30 a.m. we would round with the cardiology and or heart failure team. So we would round with whatever patients they had. And I liked these rounds because if I was taking care of one of their patients, it would go already through their plan, and I would just kind of pick up what they had on their plan, and then I would present that during round. Because of course, the only thing that they focus on during the rounds is cardiac related, versus us, when we round as a critical care medicine team, we kind of focus on the whole picture, right? Respiratory, are they currently intubated? How can we wean them off the ventilator? Are they eating? Versus these cardiology and or heart failure rounds, they focus more on the cardiac perspective of the patient. And so usually these rounds would start from 7:30 to 8:30, and then at 8:30 we would start our official rounds. And sometimes they would end at 12 or 1. It just depended, of course, how busy the day was. If the patient actively crashing, then of course we would have to stop rounds. Were we extubating the patient at that time, then we had to stop rounds. But I really, really, really enjoyed this rotation. I got to do a lot of bronchoscopies on these patients. I got really good with bronchoscopies. And I was able to get really good also with placing IV lines, ultrasound IV lines, especially when nurses can't get them. I always ask them if they would let me try to look for the one. So I got really good with ultrasound guided IV lines, getting blood cultures, etc. So anything IV, I really got good with. I was able to get my second intubation during this rotation. And given that I was with a lot of anesthesiologists, they were very willing to give up their intubations on their patients, because usually the rule is if it's your patient and then there's any procedure, then it's your procedure. So of course, I'm not going to go and steal procedures from other residents if it's their patient, unless of course they want to give them to me. So since a lot of them have intubated a lot of patients and most of them were PGY2s or 3s, they had already a lot of experience intubating, so they would let me intubate their patients. So this is definitely where I got my second intubation. I was actually using a gyroscope this time, which is a lot easier to intubate patients. And then on top of that, it also makes your attending comfortable because they're able to see on the screen what characteristics or what anatomy you're looking at while you're passing your gyroscope. So that was another thing I really liked, is I got to use a gyroscope, which is amazing. And like I said, I got to learn about LVADs, left ventricular assist devices, ECMO, how to troubleshoot an ECMO, and hemodynamics, which is amazing. Preload, afterload, what is consistent in preload, what is consistent in afterload, cardiac output, etc. And so just anything cardiac, I felt more comfortable, and I really enjoyed this rotation. Long hours definitely during the week, but like I said, weekends we got off early, so I kind of made up for it. But just the wealth of knowledge I obtained from that rotation, I'm definitely going to be able to use that in other rotations. Learning how to treat and or identify any type of cardiogenic failure, right? Also LVADs. I didn't know anything about LVADs, left ventricular assist devices, until I started this rotation. How to care for a post-CABG patient, right? How to recognize things like your cardiac tamponade, which is something I didn't think I would ever see. And then I got really good also with my ultrasound skills. So focusing, we call it focusing, point of care ultrasound. I got really good with being able to get good cardiac views. So being able to look at the heart very good with your ultrasound, right? Being able to look at the different types of views, suprasternal, substernal, your apical views. How does each view look on the ultrasound? What is the difference between a hyperdynamic heart, which is the difference between a hypodynamic heart? How can you even recognize Takotsuba's cardiomyopathy, which is really common in your critical care medicine patients? So hopefully this video is helpful. I don't want to keep talking, or else it's going to be very long, but I do have to say that this was definitely one of my favorite rotations thus far. So this is my 5th month. I will be making a video in regards to my 6th month. My next rotation, I'll be going to the medical ICU, so we'll see how it goes. Thanks for watching my videos, and I'll talk to you guys later. Bye.